Thank you very much for inviting me to give this talk on results of the ESTAMPA study. I am Maribel Almonte from the International Agency for Research on Cancer. So the ESTAMPA study is a multicentric study of cervical cancer screening with HPV testing and assessment of triage methods in Latin America, and is currently being carried out in 12 centers across 9 countries in Latin America. The main aim of the study is to investigate the performance of emerging cervical cancer techniques that can be used in primary screening and triage among women 30 years and older. And the second aim is to evaluate the feasibility of different approaches for implementation of organized HPV-based screening programs. During this presentation, I will refer to the first aim, since is the topic of this meeting. So our study aims to recruit 50,000 women aged 30 to 64 years who are being screened with HPV testing and PAP due to local regulations, by which PAP should be used in every single woman. Women who are positive for either test attend colposcopy, and those who have any lesions, CIN2 or worse, are treated accordingly. Women who do not have CIN2 or have a negative colposcopy are recalled 18 months later for a second HPV. That again, if it is positive, women will attend colposcopy and all the loop will be repeated. Those with CIN2 or worse lesions will be treated, and those negative will exit the study. Sorry. Okay. At any point in the study, when women leave the study, they leave the study with specific medical indications to go and continue receiving regular local care. In particularly, those women who are treated and leave the study, usually the follow-up care is done by the same clinician, as most of the clinicians that are involved in the study are treating women in the area covered by the hospitals where they work for. We have 2 main study outcomes, which are high-grade squamous intraepithelial lesions using the last criteria, by which CIN2 lesions are confirmed with P16 immunohistochemistry, and this is done on reviewed histology. Reviewed histology is done by a panel of experts, of international experts, who actually are reviewing every single specimen, histological specimen that comes out of the study. A second main outcome is CIN3 or worse lesions on local histology, and is being used to evaluate some of the first results of the study, as the reviewed histology will make, to complete the reviewed histology may take longer. A secondary study outcome is CIN2 plus on local histology, as we still work with CIN2 as a cutoff for treatment. All the cases that are detected here at entry or at the 18-month visit will be counted as study outcomes. However, for this presentation, I will focus on cases of CIN3 plus detected at entry. In the ESTAMPA study, we aim to evaluate different triage tests, those that are cytology-based, PAP, liquid-based cytology, or dual-stain cytology using P16 and Ki-67, visual tests like visual inspection and colposcopy as triage, and molecular tests that can be HPV genotyping, methylation, as well as other triage strategies that I'm going to show you. We collect specimens at the initial screening, a majority of specimens that are going to use for molecular testing, in a way to simulate reflex testing whenever possible. In addition, we will collect some specimens at the time of the initial colposcopy on those HPV positive or with an abnormal PAP, and a blood sample for future serology tests that may appear in the coming years. All the triage tests, with the exception of PAP, will not be used for clinical management, And the tests will be done locally in regional hubs or in expert centers outside the region, usually will be done after we have ascertained the study outcome. Not all the tests of strategies will be evaluated in all centers because some techniques are going to only be used in certain countries and centers, as I'm going to show you soon. So I'm going to refer to the population recruited as of April 2020. By that time, we had recruited above 40,000 women, but we only had 39,829 with available HPV results at the time of analysis. 14% of them were HPV positive, and this HPV prevalence has been consistent all over the study since it started in 2013. Among these 5,605 HPV positive women, 91% had already attended colposcopy. And I'm going to show you results mainly in 4 technique strategies: PAP, visual inspection, a short-term second HPV test, and HPV 16-18 genotyping. So I will start with PAP as triage of HPV positive. PAP was done in all our study centers because even though in some countries HPV testing is already included in cervical screening guidelines, it may not yet be implemented, or the region where we were doing the study may have not started using HPV in primary screening. And then in the majority of countries, in reality, cytology is still the only way of doing cervical screening. Also, the HPV status of smears when they arrive at laboratories was unknown in general. We decided to classify the laboratories by the type of organization, whether they were public or private, and by the type of interpretation protocol they use. We found out that some of the laboratories that are participating in the study, in some of them, the cytotechnicians interpreted all the smears as usually recommended, and only the positive ones were confirmed by a pathologist with an additional 10% or so for quality assurance of negative smears. And in other laboratories, pathologists actually interpreted all the preparations. So we thought that these 2 characteristics may actually lead to different results, and we decided to classify our laboratories by them. It has to be noted that in one center, only PAPs from HPV positives were prepared and interpreted. In a way, the cytotechnicians didn't know that the smears were from HPV positive women because this is a public health laboratory that received many smears per day, and the ESTAMPA smear did not differ from any others that arrive daily at the lab. So for this analysis of PAP as triage of HPV positive women, we had a population of 4,661 HPV positive women. And as you could see here, all of them had a PAP smear with results that went from unsatisfactory to PAPs diagnosed as HSIL or worse. And in these 4,661 HPV positive women, 466 CIN3 cases occur, and of them, PAP was able to detect 251 at the level of ASCUS, 212 at the level of HSIL, and 155 at the level of HSIL. In addition to this, I have to say that the laboratory where the smears only from HPV positive women were read and were prepared and interpreted, the number of CIN3 plus that were detected was higher than in any other lab. Another strategy that I wanted to show is one that was proposed by one of my colleagues, taking advantage of our study design, by which when women come to colposcopy, we collect another sample using a swab instead of cytobrush for clinical reasons, and then we use this sample for a second HPV test. This sample was collected at the time of colposcopy that actually happened in 50% of women at about 1.7 months, and in the majority of them before 2.5 months. And here I show you the number of cases that were produced among 62% women that remained positive at the time of colposcopy, and in 38% of women that actually turned out to be negative. And we could see that the majority of CIN3 and cancer cases actually occur in the group of that actually were positive twice in a short time period. The next strategy I wanted to show is the HPV 16/18 genotyping used as triage of HPV positive women. Among 13,814 women who were screened with COBAS in Argentina, Colombia, Costa Rica, Paraguay, and Peru, we actually had 1,605 of them who tested positive for HPV, and because they were tested with COBAS, had an individual result for HPV 16 or HPV 18. Among them, 28%, 456 women, tested positive for 16 or 18 or both together, while 72% tested positive for other high-risk types not different from 16 or 18. Among the group that were positive for 16 and 18, the majority of CIN3 plus cases, 60%, occur, compared to only 75 CIN3 plus that occur in the group that were positive for other high-risk types. In this group of 28%, the majority of CIN3 plus were also detected by this strategy. We also thought on adding PAP as a second triage on this group of women in a way to find out whether this will increase the sensitivity of the strategy without losing much specificity. And I'm going to show you a final result at the end on this. Next strategy we evaluated was visual inspection as triage of HPV positive women. Although most of the countries and centers that are participated in our study come from upper middle countries in Latin America, the majority of our countries have different settings due to geography, cultural, or other differences. And so visual inspection should be considered to actually a potential way to reduce inequalities in access to care. So we use our study design once more to actually provide visual inspection at the time of the colposcopy visit on women who tested positive for HPV at the initial screening in Bolivia, Colombia, Honduras, Paraguay, and Peru. The visual inspection was done by a trained examiner that could be a nurse, a midwife, or a general doctor, and they will perform the exam without disclosing or discussing any observations or BIA results with the colposcopist that usually enter the room afterwards. In this group of women, 182 CIN3 plus cases occur. Here I show you the positivity of the test, which was 55% overall, and also show you that there was a 3% of results inadequate, that actually most of them started happening at age 45 and over, and actually increased at age 50 and over. Also here I show that the positivity rate increased substantially with age. And it is also worth noting that of 24 CIN3s and 8 cancers that occur in women over 50 years of age, 20 CIN3s were detected by BIA and 7 cancers were detected by BIA. So overall, BIA was able to detect 156 cases of CIN3 of a total of 182. Finally, I wanted to show you a new exercise that we are doing under an NCI Affordable Cancer Technologies Award. We have teamed up with Arbor Beta to develop and validate a new oncoprotein test. So there is an available OncoE6 cervical test by Arbor Beta that actually using oncoprotein, E6 oncoprotein expression targets HPV type 16 and 18, and it's a strip test that is very easy to carry out. It's simple, it's easy, it's low cost, and it only takes about 2.5 hours. So we thought, based on a previous prototype developed by the company, that if we actually refine the prototype that they propose with 8 types, we could improve the sensitivity of this test that has also been evaluated in several studies and show a limited sensitivity of about 55%, but a high specificity of over 95%. And so we thought, like, if we can modify the test with 8, targeting 8 HPV types, maybe we could increase the sensitivity while maintaining the high specificity, thinking that if that happened, this test could be actually very useful for low or limited research settings. So we did this validation using a convenient sample of ESTAMPA. So this sample doesn't represent a screening population. As you could see, the number of CIN2, CIN3s is enriched in comparison to the people that test negative on a screening population. And also furthermore, of these 98 cancers, about 65 of them came from cancer centers that were not involved in the screening process of ESTAMPA, but that we recruited particularly for this evaluation. For this evaluation, we use the dry swab collected at the initial screening. For doing the oncoprotein testing, we use 1 aliquot on preserved from the initial screening as well to actually do the HPV genotyping in order to associate disease to HPV, to identify disease related to HPV DNA different types that actually are the same times targeted by the oncoproteins in the test. And we also use a sample collected at colposcopy in a small exercise to see if the test actually produce similar results between self-sampling and clinician samples, just as a preliminary evaluation. And of course, again, the outcome of this evaluation was CIN3+. So I have to say that we found for this validation, we found that the test actually reached about 60% sensitivity for CIN3+ detection and 73% sensitivity for cancer detection. And when we look at the specificity, the test was still very specific when we look at each of the 8 HPV types targeted. But when we look at the 8 types together, the specificity was a bit lower. However, we are doing a lot of refining of the test in collaboration with the developers, and we will have a new version of the test that will be evaluated on a screening population. So finally, I have to say that I've shown you some results from evaluations of PAP, visual inspection, repeat HPV test, HPV 16 and 18, as triage for HPV positive women for CIN3+ detection. we have observed that PAP and HPV-16 have limited sensitivity of 60% or less, while the repeat short HPV testing strategy and VIA show better sensitivity, but still moderate at about 85–86%. The sensitivity of PAP was 15% higher in the laboratory, as I told you before, where smears from only HPV positive women were interpreted compared to any of the other laboratories and to all the laboratories as a whole. When we add PAP at the ASCUS level to triage women who were HPV positive and then positive to high-risk types different from 16-18, the sensitivity of the strategy of HPV 16-18 was increased by about 10–50%, with a similar but not larger decrease in specificity. And as we went up the threshold for PAP, the increase in sensitivity was lower, but so was the decrease in specificity. I also wanted to note that probably our good results and our high, let's say, moderate sensitivity of VIA is due to few examiners participating in this evaluation with a large expertise on the technique. In countries like Peru and Bolivia, VIA is quite frequently used, and the nurses and doctors that participate in doing these examinations are used to perform the exam daily, usually. I also have to say that PAP had the highest specificity, as I've seen in many studies, even as the main primary screening test, followed by HPV 16-18, while the other two had limited specificities of less than 50%. So I have to say that so far in our study, no single triage test or strategy offers a final answer, but we plan to continue evaluating, and we are still already ongoing with further evaluation of different triage tests and modifications of the techniques that we are evaluating. So, for instance, we are now running a protocol to evaluate the performance of PAP when the HPV status of women is known. We are also evaluating visual inspection at the screening visit and at colposcopy by a different provider to account for potential correlation between the VIA and colposcopy results. We are evaluating, we are now testing, actually we are doing the preparations and the interpretation of dual stain cytology in a hub in Costa Rica, and we are planning to soon start doing HPV full genotyping and methylation using sequencing at the NCI in the United States. We are also now preparing the analysis of colposcopy as triage of HPV positives using the second visit at 18 months to confirm disease in those women that had negative colposcopy or didn't have disease after the initial screening. I've shown you, using a convenient sample, the first results of the new 8 HPV type OncoE67 test that show limited sensitivity, only 60% for CIN3 plus and 73% for cancer, but also show high single oncoprotein specificity, above 95% for each of the 8 oncoprotein types to detect CIN3 plus. And we've been working on a further refined version of the test that will be evaluated in the ESTAMPA screening population, both as a standalone test, like in primary screening, and as triage for HPV positive women. Finally, I want to say that all screening techniques or strategies will be evaluated alone and in combination using high-grade squamous intraepithelial lesions as the main outcome, as it is the main outcome of the study, under the last criteria, again, by which any CIN2 is confirmed with P16 to become HSIL, including cases detected at initial screening at the 18 months visit. And I want to finish by thanking all the STAMPA investigators and all our collaborators around the world, and also the STAMPA study team at IARC. Thank you.